So I'll go ahead and introduce the first speaker. So Dr. Irfan Hussain is the Assistant Professor of Emergency Medicine, Emory University School of Medicine. And
All right. I appreciate the introduction. So, a few other hats that I wear. I'm the Associate Medical Director for two local EMS agencies, Sandy Springs Fire Department and Metro Atlanta Ambulance Service. Today, I'm going to be talking to you guys about decontamination as it relates to pediatrics specifically. So, objectives for this lecture, we're going to be talking about pediatric-specific risk for chemical exposure, some initial actions that you'd expect to take in the field. We'll talk about field decontamination versus hospital decontamination, different levels of PPE that you can expect your responders to be wearing, and then decontamination risks, and then decon strategies specific to pediatrics. So children have unique anatomy and physiology that can lead to increased vulnerability during a CBRNE event. Here's a summary of the risks that you can expect due to those anatomic and physiologic differences. So given children have a less mature immune system, they may be at increased risk for poor outcomes from serious infections. Children also have a higher surface area to mass ratio, making them more susceptible to heat loss or hypothermia, as well as contact toxins. Thinner skin increases the risk for dermal absorption of toxins. Many airborne toxins are also denser than air and settle closer to the ground, increasing exposure. Additionally, children have higher respiratory rates, therefore taking in more of the toxin. Also, depending on the child's age, they may lack the necessary communication skills, motor skills, or basic defense mechanisms to escape danger, therefore prolonging exposure. And then another risk as well to take into account is the long-term psychological effects. So initial actions: when responding to reported hazardous materials release, personnel should approach the incident from an uphill upwind direction to protect against contact or inhalation. An inner and outer perimeter should be immediately established by the initial arriving agency. The United States Department of Transportation's Emergency Response Guidebook, which has gone through many iterations. It's a great tool to not only lays out the potential hazards, public safety information, emergency response recommendations by specific chemical, but also can help determine the size of the perimeter. The first arriving unit should establish single agency incident command and then transition to a more unified command as more agencies arrive. In identifying the agent or substance should try to be done immediately, because there's a lot of things that kind of depend on that. The expected health consequences of exposed victims, the risk to rescue personnel, appropriate selection of PPE, decontamination procedures if they are required, and initial treatment. So for field decontamination, EMS will work with hazmat and other emergency management personnel to establish hot, warm, and cold zones of operation during release of hazardous materials, including chemical, biologic, and radiologic weapons. EMS providers will commonly be staged in the cold zone and care for patients after they've been deconned in order to avoid secondary exposure. In general, the majority of EMS providers will only have access to level D PPE and not have training in higher levels of PPE. Field decon should really be reserved for specialty trained hazmat teams and will occur in the warm zone. The zone is usually set up adjacent to the location where a chemical agent release has occurred. Hazmat teams usually wear level B or C PPE when performing decon. And in general, the level of PPE donned by the decontamination team members should really be no more than one level lower than the entry team. Later in the presentation, we'll go over the different levels of PPE, how they differ, and pros and cons of each. So taking a tiered approach to patient decontamination allows responders to base the nature and level of decontamination on the type and extent of contamination, as well as resources and capabilities of responders on scene. This approach allows flexibility and a scalable approach that really ranges from limited actions that patients can take on their own to actions that require equipment and supplies. And so depending on the exposure type and extent, some tiers may not be levels required, of PPE, and then also depending on available resources, some tiers may have to be done in the hospital. So self-care involves actions that a patient can perform for themselves, including distancing from the site of release, removing clothing, wiping visible contamination from the skin or clothing in order to reduce contamination levels immediately without waiting for a formal decontamination process to be set up. Timely removal of patient's clothing can reduce contamination secondary exposure by as much as 85%. The gross patient decontamination. The goal of gross decon is to achieve a so self-care involves actions that a patient can perform for themselves, including distancing from the site of release, removing clothing, wiping the decontamination system to provide a high volume, low pressure water shower from a fire apparatus. And then lastly, technical timely removal of patient's clothing can reduce contamination secondary, requiring more equipment. It usually involves a high volume, low pressure water shower, plus or minus soap, gentle rubbing with a soft cloth or sponge. Later in the presentation, we'll go over pediatric-specific decon strategies that we can try to implement. Here's an example of a ladder pipe decontamination system. As you can see, water is coming from the sides as well as the top. And here's an example of what a technical decon would look like. You ideally want to have kind of the gross decon process happening in the hot zone. And then as patients are moved into the warm zone, the decon process will start. Any kind of remaining clothing will be removed, and then multiple potential cycles of wash rinse will occur. And then the patient will be moved to a clean stretcher and have clean clothes placed and be transitioned into the cold zone where paramedics will be waiting in order to transport the patient to the hospital. Decontamination in the field can be challenging, especially when caring for children, as resources are often limited. If decon is set up by fire EMS, they're often not able to control temperature and water pressure. For example, the fire department may use a fire hydrant as a water source for mass decon, and oftentimes wash rinse will occur, large amounts of age-appropriate towels, gowns, or blankets. Also, from a preparedness perspective, children are oftentimes not included in decon drills, and agencies lack PEDS-specific protocols. How can we address these challenges? In order to avoid hypothermia, dry children immediately, ensure an adequate supply of blankets and age-appropriate gowns. Another strategy is to increase the ambient temperature within ambulances during transport. Oftentimes, hazmat teams will invest in pop-up tents and portable water heaters or decon trailers that can be brought to the scene. These can allow for warm water and the ability to control water pressure. Also, trailers can be stocked with blankets, gowns, and devices to safely secure young children during the showering process, so they're not carried, therefore kind of avoiding any trauma. The most important thing EMS agencies can do, though, really is to develop PEDS-specific decon protocols in conjunction with local partners like the hazmat team. Hazmat teams will invest and then be practiced through decon drills that include children. So after a large-scale exposure, many patients will leave the scene without being decontaminated or evaluated by EMS, and will self-transport directly to the hospital or emergency department. These patients may or may not have performed all self-care actions. So hospitals often decontaminate patients prior to entry into the building unless decontamination is confirmed to have occurred in the field. Unlike first responders in the field, hospitals may be alerted in advance of hazardous exposure concerns and any prior decontamination efforts. Hospital staff can decrease their risk for exposure by wearing full PPE and respiratory masks until it's clear that the secondary exposure risks have been eliminated. Level CPPE also meets OSHA's first receiver expectations and is most often used by hospital personnel while performing decon. On the right is a diagram going through the steps of the pediatric-specific hospital-based decon process. Here you can see that victims will arrive. You can basically identify the children amongst the victim, and then here children families should not be separated until it's kind of medically critically necessary that they have to be separated. Then you're going to kind of divide the patients into non-ambulatory, ambulatory. For non-ambulatory, disrobement is going to happen by child's caregiver or the hot zone personnel, and then placed on a stretcher or restraining device, and then they'll be escorted through the decon shower with direct supervision. For ambulatory patients or for ambulatory children, you'll try to estimate the age by visual inspection and then break into school age, preschool, and infants and toddlers. So 8 to 18, 2 to 8, less than 2. For school age children, you'll have them disrobe without assistance. So they'll do it themselves. You'll try to, you want to obviously respect their modesty and privacy, and then they'll decon themselves through the shower. And ideally you want to have them do it in succession with their caregiver. Preschool, they'll need assistance with disrobing and then direct supervision. Also, it's important to kind of monitor their airway through the decon shower. And then infants, the key takeaway here really is making sure that the caregiver should not carry the child due to the risk for accidental trauma that can result from falls or drops if the child slips. And then ultimately, you want to make sure you treat and prevent hypothermia through use of towels, gowns, and warming blankets, as well as making sure you are identifying patients through wristbands. Also, an important resource, if available, will be child life personnel. If you're unfamiliar with child life personnel, they're basically professionals who help reduce the stress and anxiety that many children may experience in the hospital setting through their kind of playful interactions that they have with children. And they should really be included as members in the decon team. So in order for responders and hospital personnel to operate safely and effectively, selecting the correct type of PPE and understanding how to don and doff is essential. All personnel must understand the operational limitations of wearing PPE, especially levels A through C, such as limited dexterity, reduced hearing, muffled voice communications. And for this reason, frequent training is key. So let's go through the different levels of PPE real quick. Level A is the highest level of protection. It's usually only worn by hazmat personnel who enter the hot zone because it protects against vapor and splash threats. It consists of a fully encapsulated chemical-resistant suit, positive pressure, self-contained breathing apparatus, double layers of chemical-resistant gloves, and chemical-resistant boots. Then level B PPE is used when full respiratory protection still is required, but dangerous to the skin or less. It consists of a chemical-resistant suit, resistant gloves and boots, SCBA, and then so for level B PPE, there's less vapor protection. Level C PPE is required when air concentrations are expected to be much lower and there's less likelihood of skin exposure. It consists of a non-encapsulating chemical-resistant suit, gloves, and boots, and a PAPR. And then you have level D protection, which is used only when no danger of chemical exposure exists. And it consists of standard work clothes and no respiratory protection. Hazmat teams usually wear level B or C PPE, like we mentioned before, when performing decon. As previously mentioned, level C meets OSHA's first receiver expectations and is most often used by hospital personnel when performing decon. In general, the majority of EMS providers will commonly be staged in the cold zone after full decon and will usually only have access and training in the level D PPE. However, you'll find that some EMS agencies will train their personnel in the use of level C PPE. All personnel involved in the chemical response or treatment should really be aware of the entire decon process, including the potential risk to children, not just during the exposure stage, but also during the decon stage as well. So as we mentioned before, children have thinner skin and a larger body surface area than adults. So exposure to cold water will increase the risk of hypothermia. Other factors that will increase chances for hypothermia or lacking age-appropriate gowns, adequate supply of blankets and warming devices. Also, children's skin are more fragile and prone to injury with the use of hard bristles or brushes. And non-ambulatory children are also at risk of injury if they're carried through the decon shower, as they can easily slip if they're carried by first responders in PPE. Children may also be frightened and resist. So avoid carrying children through the decon shower. If children are poorly positioned, the combination of high pressure water and lying flat can lead to respiratory complications. For children, ultimately we want low pressure, higher volume, and having the child positioned upright. Ultimately, the decon process can be scary for children, especially if they've been separated from their family. And in the moment, they may not be able to grasp what exactly is happening. And with that in mind, children may also be frightened and resist is key, and identifying and tracking children through the decon process as well is important. So pediatric decon strategies, personnel helping with decontamination should receive training on the vulnerabilities of children and how to address these. Children may be accompanied or unaccompanied. And if unaccompanied, make sure a team member has identified the child as being unaccompanied and remains with the child during the entire decon process. For accompanied children, keep the family unit together during the process and be cognizant of the fact that guardians may need an extra hand. Keeping children with their caregivers may help reduce psychological stress for all family members. And children can be uncooperative due to removing comfort items like blankets, pacifiers, toys, or just being in an unfamiliar environment. So it's important to kind of take that extra time to communicate and explain things based on their developmental level. So as we talked about before with communication, be sure to communicate at the child's developmental level. However, communication can be difficult for those performing the decon, especially when wearing PPE. So consider implementing, creative measures like instructional cartoon videos or illustrated posters to help with the decon process. And as previously mentioned, children's skin is fragile, so avoid harsh chemicals and things based on their soap or developmental water, and use soft bristle brushes or soft sponges. A method to carry an infant through decontamination must be in place as well. And this could be in the form of using like a laundry basket or a bassinet with holes for drainage. Due to increased risk for barotrauma or hypothermia, use low pressure water system with warm water. And children that normally take showers on their own may need some assistance or adult supervision, but it's important to balance privacy while also making sure decon is done properly. Older children may want to decon separately from their parents, which can be a discussion between them. But ultimately, it's important to make sure they're reconnected after decon. And so here's an example of a pediatric decon checklist. And this checklist ensures that the needs of children are met prior to, during, and after undergoing decontamination. So this can be used as a reference.
Thank you, Dr. Hussein. I don't have any in the Q&A, but I have a question, maybe a big task, tall order to ask for you because you have quite a lot of detail, great information. But can you just kind of in summary, what are probably you would pick as the three most important points?
If I had to pick like probably the top ones really are really having and this checklist ensures that the needs of children are met prior to, during, and after undergoing. For all the stakeholders involved, having kind of planned training and drills, because in the end, kind of preparation is as well as, when it comes to pediatric decon specifically, making sure
just kind of in summary,
personnel, probably kind of like I mentioned before, the vulnerabilities to kind of look at, not just with exposures, but also kind of through the actual decon process themselves, because with children, they're, at greater risk, like we talked about, for certain things compared to adults.
All right. Thank you, sir. Appreciate your contributions today. And just as a follow-up for everybody, we'll be sending out the information and slides and such later, which I mentioned in the chat. Wonderful at the end. Thank you again, Dr. Hussein, for your participation today.